Well, thank you both for joining us today. I think all of the other panelists have been fantastic. And we won't tell them this, but I think you guys will probably be the highlight, not to, cause you any anxiety or not. But like I said at the start, it's very rare for any of our members to have more than like 7 to 10 minutes with their MFM a couple of times over the course of their pregnancy. So to have two live real ones to talk to is really exciting. And you're both my favorite people as well. Disclosure: Mark and Tom are both on our clinical and scientific advisory board. You'll see their pictures every once in a while, and little tidbits that they offer us. And they do so voluntarily and freely, providing their skill and experience and time. So thank you both for that. I'm going to let you both just introduce yourselves, and then we will get started with some questions. Mark, we'll let you go first.
Okay. My name is Mark Santillan. I am a maternal fetal medicine subspecialist here at the University of Iowa, and I run a translational basic clinical lab investigating lots of different things about preeclampsia, from the molecular to kind of the clinical and what happens even after preeclampsia. And so that preeclampsia from a clinical and research focus is a big thing to me, and that's sort of my drug of choice, I like to call it. And so now a lot of the work we're doing is in conjunction with roles that I have here at the university in the Institute for Clinical Translational Science, as well as the Intellectual Developmental Research Center, where we're looking at sort of downstream effects of preeclampsia, like neurodevelopmental issues in kids. So my work sort of spans throughout.
Cardiovascular disease as well.
Yeah.
It's a
Hmm.
big one for you. Yeah. Great. Thank you so much for joining us, Tom.
Hi, I'm Tom McElrath. I am a attending in maternal fetal medicine at Brigham and Women's Hospital in Boston, a professor of obstetrics at Harvard Medical School, and professor of epidemiology at Harvard School of Public Health. At Brigham and Women's, I am the principal investigator of our biobank, which collects samples from volunteer patients during pregnancy, and we use them in a variety of different ways. My lab is most interested in looking at the environmental exposure effects during pregnancy and how that affects pregnancy outcome, including preeclampsia, and then equally interested in looking at developing biomarkers and tests that we might develop to help see who's at risk of adverse pregnancy outcome, including preeclampsia. So I agree with Mark that this has been my quote unquote drug of choice for many years, but it is also probably one of the driving concerns of patients in our clinics.
Yeah. Well, thank you both for that. I think we'll maybe have a little note on this later about how our members who can contribute to biobanks, whether they're yours or in their own home states with their own physicians, seeking out places to be able to contribute maybe blood tissue samples in order to support research. That is a great way to participate. As Jennifer was the panel before was talking about, being brave to volunteer, and maybe studies where they're testing a new therapy or medication. Maybe that's not your jam, but sharing of your blood samples for researchers like you guys to be able to study and utilize down that road is equally as important. So good to hear that both of you about your biobank work. So, all right. So today we wanted to talk about communication and MFM appointments. What happens, with when somebody's told that they need to see a maternal fetal medicine specialist, and also what happens if they feel like they need to see one but aren't able to get a referral. I And this was, I think, Tom's suggestion early on when we were talking about this, is to kind of talk about this in the arc of a pregnant person's, life through the pregnancy. So like pre-pregnancy or early pregnancy. Jennifer talked earlier about screening tests. We know there are some risk factors that exist. So if somebody has been told, a patient has been told that they're at risk for preeclampsia, and they need to see an MFM, what can they expect at that sort of first appointment? And when does that kind of occur for you guys?
So we're both sitting here wondering who's going to start. So um, it can occur in a bunch of places. Yes, exactly. It can occur in a bunch of places. Ideally, it's before the patient thinks about getting pregnant. The ideal time to have a consultation about a history of preeclampsia or a risk for preeclampsia is pre-pregnancy. And then to make sure that things that can be changed are being changed. Blood pressure medications, if they're needed, are optimized. That if possible, exercise regimes are optimized. Weight management may be something to consider. And then, in addition, just simply being on a vitamin, prenatal vitamin, and being prepared for the pregnancy and the potential reoccurrence of preeclampsia. Very often that doesn't happen, and the next best time to probably see your maternal fetal medicine doctor is in your late first, early second trimester. So sometime around 12 to 14 weeks for a plan for essentially the same things. Management of blood pressure, optimization of blood pressure medications, potentially setting up a home monitoring system for following your blood pressures, using a cuff correctly, what to do, what to look for, education, what to look for in terms of symptoms. So this would be a whole set of criteria. There are very few things that are really high risk for preeclampsia, but having had preeclampsia is one of the few that is really high risk for preeclampsia. I will turn over to Mark.
And so one of the things that you mentioned that I would also add in terms of risk factors, right? So our diabetics, that the better that they are better controlled, less likely to cause more kidney damage. So that's something we often talk about, even a priori. We call it the MFM trifecta in Iowa because it seems like it's the majority of our patients where it's everything that leads up, the common things that add up to preeclampsia: obesity, diabetes, and chronic hypertension. That's sort of like our baseline patient here. And then there are other things too. And so one of the things that when we get consults from outside physicians, like, here, I need you to talk to this lady about this, is one, aspirin is now pretty well kind of implemented through, at least in our state. But like the newer things of, well, if you're at higher risk, do you take one or two? And I know Majid, did Majid already talk?
He did.
Okay, he already did. Okay, so there's clearly that question out there about whether or not to do one or two. And then kind of sometimes outside, when I say outside physicians, I mean not non-MFMs where we're doing the consult, may not automatically get a lot of the baseline things that we think we need to get, like CBCs, liver enzymes, the kind of baseline stuff that we would ask them to get in the first trimester, just to see, all right, this is your, if you're diabetic, you're going to spill protein anyway, but let's see what your baseline is before we go. And so those are, I think, in my mind, always the earlier the better, and modify what we can modify.
So you mentioned, Tom mentioned the we call it the preconception consultation. We find that our patients have trouble getting that booked. Either either they haven't been referred to MFM and they maybe think they should be, and their OB won't refer them, or they actually call your office and can't get in until they're pregnant. Like, oh, well, he can see you at 12 weeks or whatever. Um, and we have some like tips and tricks around that, but I'd love to hear like how you would consult our patients to have those conversations.
So this is a problem. There are fewer and fewer practicing OBGYNs, let alone MFMs in the country. And in the next 5 years, I think we'll be down 5,000. So we're basically losing 1,000 a year who practice in this field for a lot of reasons. So getting in to see an OB provider of any kind is increasingly difficult. The one thing I would suggest is persistence. Uh, Sometimes, it may have to be an awkward time or an inconvenient time to have the consultation, but if the consultation is important, it may have to be at a time that wouldn't be otherwise ideal. Asking your provider, whether it's your midwife or your generalist OB, to advocate for you and say, could you just send them an email? So frequently doctors will respond to other doctors out of courtesy in a fashion that might be more positive than if someone just calls the office. So that's another way in. So it's a problem. It's a problem we all wrestle with.
And I would assume, Tom is, a preeclampsia expert at Brigham and Women's. I'm often, and people know that, again, preeclampsia is my drug of choice. And so a lot of times that those very simple requests to whoever, just I mean, the scheduling system in any major institution is ridiculous, and that is a fact of our existence. And to get into an appointment is hard, but particularly, I mean, the good thing is if it's a pre-pregnancy, often those actually you can get in a little bit easier, at least in our experience, because it's a less involved visit and it's a simple consult. And so certainly in Iowa, where we've got as you mentioned, there's not many OBGYNs here and more or less MFMs. I mean, we can implore like telemedicine services where we're at, which makes things a little bit easier, because then at the end of the day, if you are like myself, if like somebody wants to talk to me about preeclampsia, I will talk about it all day, every day. And so if there is and occasionally I'll get consults of like Santillan to see regarding last preeclampsia pregnancy or whatever. And I will often open up my calendar and it's like, oh, I can telemedicine and talk to her about that. So yeah, just taking that extra step to advocate for yourself, to have your provider advocate for you, it's not seen as annoying. It's more like, oh, great, somebody knows what's going on, and I'd much rather have that than someone who's like, oh, I didn't know I should have stopped smoking and stopped all of these other things that may be potentially modifiable, or
Yeah.
And a lot of times we're doing much more with the Zoom consult, with the telemedicine. I can't remember the last time I had an in-person consult. And those allow flexibility. I will do them during my lunch break with a patient if they're able to make the time. I think the teleconsult actually offers a lot more flexibilities, but patients should also understand that, I mean, we are doing stuff like that. We are booking things during our lunch break, and we're booking them, we're staying late in the day. We are flat out with a lot of these requests. It isn't that we're off at the golf course or something like this. It is a pretty heavy demand.
I don't like golf.
Yeah, me neither. I mean,
I hate golf.
No golfing here. I think, one of the challenges our patients have is in the care provider who doesn't think that they need to see MFM. And so we generally, our advice, and you can tell me if we're doing it wrong, but our advice is if you've delivered before 34 weeks, and you have some risk factors, that would be a good reason to push for that consult. Any other, because we also don't want to send people to you that don't need to come to you, right? So because that, if you're overtaxing an already overtaxed system, then the people who do need the MFM care aren't getting it, and so we try to help them figure out what is the cutoff, and it's so hard, with factors that we just say, hey, if you deliver before 34 weeks, that's probably worth at least a consult. Um, any other?
I would add to that list, if you may have had like a 36-week severe preeclampsia and then you just spontaneously went to HELP syndrome. So anything that looks like severe in a previous pregnancy, and if they have other comorbidities, clearly like diabetes, lupus, chronic kidney disease because you had preeclampsia last time and all of that, because that's kind of one of the common things that I see. They had preeclampsia before, they just assume that their 24-hour urine is going to be super duper high, and they're like, oh, the spot was fine. A 24-hour doesn't get done. When by the time I see her, they're in nephrotic range and their kidneys are really shot, which puts the big question of could it have been something else other than preeclampsia? And so anyone with any of those like extra risk factors, I think, would qualify in that space to see an
Yeah.
MFM.
Well, I
Um,
think what I would add is if your provider doesn't think you need an MFM consult, ask them why. Why do you think I don't need an MFM consult? And if if it makes sense, then I think
we
that's
do ask that
satisfying.
question, and the answer is usually I handle high risk patients, so I can handle your scenario. And sometimes I think they absolutely can, and other times they can't. So um,
Um, I think it's once again, it has to be an advocacy, a self-advocacy, and say,
yeah,
no, I understand it, really appreciate it, but would love to talk to somebody. Obviously, it has to be handled in a fashion that doesn't sound antagonistic, but I think just starting with, I had preeclampsia. I delivered at 32, 34 weeks. Why shouldn't I see
yeah.
an MFM? So I think that's probably at least a start.
And I think a little bit of that is also very site specific, right?
Yeah.
In a place like Boston, where there's probably 4 hospitals per square foot there, like in Chicago, where I
That's
do.
like 6. Yeah.
Yeah, oh, I'm sorry, 6. I got that wrong. Right. So the access issue is very easy, but like we get patients where if they get sick, they go to a critical access hospital with 1 unit of blood, maybe there, right? And so it's a completely different conversation from the counseling standpoint if they do have a history and they're out in, kind of more rural Iowa. So I think those, particularly for those who are listening that are from more rural areas, I think, and I honestly think that the providers would also be a little more open to an MFM consult if they're out, 2 hours away from a major hospital to have that discussion.
Well,
But I think that's part of it's a resource issue as well.
and this brings up a very good point too, for rural medicine is a little bit different. So that it would be not only to meet the MFM to get insight into how to care for the pregnancy, but then also who would I be sent to if I needed to be transferred?
Right.
And that implies both a response from the physician or the provider to really have that set up in the chart ahead of time. It also implies some responsibility from the patient. I'm going to potentially need to be transferred. Who's going to take care of my kids at home? Who's going to swoop in and be able to,
Yep.
make sure that everybody goes to school on time? I mean, so it's an opportunity to put all of this in place, which is just beyond the actual conversation with the MFM doc.
Yeah, very good points. All right, so let's move on to pregnant, has a preeclampsia diagnosis of some sort, hospitalized. So this is the first meeting of the MFM. They were not high risk. Now they're diagnosed and they're in the hospital. What does that usually look like?
Mark, you want to?
So this is sort of a thing that's changed over time, given what drives your inpatient experiences, how bad your preeclampsia is. If you are term and we deem it preeclampsia without severe features. I have to force myself to not say mild preeclampsia. Mold. The preeclampsia without severe features, then those people have if everything looks fine, they're not having any symptoms, and those people are not necessarily managed inpatient. Particularly and it used to be that we would admit everyone because that switch, particularly in an area that is OB poor, provider poor like Iowa, that switch from mild to severe can be very quick, and they may not have the resources to get them to us. And so it used to be that way when I started some 20 years ago here. But then it is really morphed to being able to monitor these mild patients outpatient in a reliable fashion. But it also puts it upon us that if they are coming from far away, that we have that plan that Tom was talking about. Now, for our severes, that a little bit of that they don't go home. As soon as we diagnose them, because literally that switch to needing to deliver you is even faster. And so it gives us the opportunity to watch. Now, one of the things that for people who have not spent a long time in the hospital, because it's more than like, I have appendix pain. You take out my appendix and I'm out in 2 days or even the next day, right? It is you've moved in to home. And so our patients are kind of leaving their lives. And for the most part, their lives are at least an hour or 2 hours away from us here in Iowa. And so that realization, certainly things like FaceTime and Zoom and all that stuff has made things a little bit easier. But I think from the standpoint of taking care of them, that is probably the thing I worry about the most. We've got processes to say, all right, your blood pressure gets this way, you have this symptom, you go over to labor and delivery, you get stared at by 1,000 doctors until you're perfectly fine, and then we'll send you back to the antepartum service, right? Or something funny happens and then we have to deliver you. That's not what I'm worried about. I'm worried about this kind of long-term effect we know that preeclampsia is associated with higher rates of depression and anxiety. Imagine throwing in a 2-month inpatient course on that. And I think that is the thing on the day-to-day, I worry about the most, because that's the one thing that we probably could do better on, making sure that from a mental standpoint and a mood standpoint, our patients are well cared for.
I think, to add to what Mark is saying, I think if a patient's being hospitalized with preeclampsia, the thing she needs to ask her care team, first of all, who are you? Who's in charge? Which one of you is in charge? Because the person in charge is probably the person you're going to see least often.
And are you in charge tomorrow too,
right,
or not?
And what's the change in shifts? But particularly at a teaching hospital, and for patients who have earlier preeclampsia, particularly before 34 weeks, they're likely to get transferred to a teaching hospital because there are the tertiary centers. So just trying to get a sense of who is calling the shots and who is in charge. And the next question is related. It's when would you deliver me? What are the things that need to change for you to think I need to be delivered, and get them spelled out? And most docs will be happy to have it, but this is a structured conversation. And then the next set of conversations is, what about my baby? What are the advantages of the baby staying inside versus being delivered, and when does that change? And then the third or fourth part of the conversation is probably better had with the pediatricians and the neonatologists about what would it be like to have a baby if the baby was born this week, or maybe next week, or in 2 weeks. What does that imply? So there are some structured questions around, who's caring for me, and what are the guardrails for how long I can stay pregnant or when I might need to be delivered. And those are much more informative questions, I think, than just unfortunately, a lot of times doctors go in and say, well, do you have any questions? And patients
Don't know what to ask.
look at me with you know, a stare of surprise and will say something like, I don't even know how to begin to ask the questions. So at least that gives you a sense of, who's going to care for me and what are the boundaries for when I might need to be delivered, or how long is it safe for me to stay pregnant.
Tom, thanks for bringing that up. I think we take it for granted, or I at least take it for granted, because I work at a teaching institution, and that's sort of all of the things that you addressed get addressed on days 1 and 2 when they're admitted, right? Because they see NICU and all that. And I think you raise a great point that this is sort of where we see things from a teaching hospital. But the truth is, even if you're not a you're bigger than a critical access hospital, especially in rural areas, they may not approach it the same way, but still say, well, we can deliver to 28 weeks here at this institution. But advocating for those questions that you did ask is a good thing, right? Talking about the kids and when to deliver, all that, I think that is a great point.
I remember when I was hospitalized, I was just about 31 weeks, and I was like, okay, so they'll probably deliver me a couple weeks early, so I got like 6 weeks to sit here in this hospital. And, like 5 or 6 hours later, I'm having a conversation, and the OB, who's the attending that day, was like, blah, 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 48 hours. And I was like, whoa, whoa, what? Like that changed the whole story. I had a story in my own brain, and now, and it's traumatic, and now it's more traumatic because I didn't know the question to ask. I made some sort of an assumption, but I think it's great that you share this information, that it's okay to ask these questions, encourage probably to ask these questions, because you can't remember everything, or you can't know what's important to everyone, and it's okay for these patients to ask these questions about who's going to care for them, and what is the expectation. And sometimes that expectation is hour to hour or day to day, and that's okay. Just having some sort of an expectation and being comfortable to ask those questions, I think, is really important to them. All right. Let's see. We find that OBs and MFMs manage their patients a little bit differently in different parts of the country. A lot of times, patients being cared for by both. They have an OB that they're seeing regularly, and then they see MFM every so often, or if something's going downhill. And that seems to be okay until the OB and the MFM disagree on something. And then it comes down to that patient's experience, right? Have they had babies before with that OB? Do they trust that OB? And they don't trust the new MFM that they just met, but they are feeling torn in making decision. One says this, the other says that. We typically tell them the MFM is the specialist. You should, talk to them and probably go with their instinct. But what do you guys say about that?
So, unfortunately, this happens. And it doesn't happen just with an OB and an MFM. Sometimes on a labor floor, a doctor and a nurse will disagree. It is incredibly unprofessional of any of us to be disagreeing in front of a patient. So
I disagree, Tom. I'm just kidding.
Yeah. The patient has the absolute right to say, okay, you guys head out of the room, come to a decision, and then tell me about it, because
Duke it out.
That would be, that is a legitimate, although a very difficult thing to ask, but it's a legitimate point. But I think you, as the patient, are entitled to ask each one, okay, get back to those questions. When would you choose to deliver me? Why are you saying I need to be delivered now? When would you choose not to deliver me? Why are you saying I don't need to be delivered now? And then ask the MFM, same set of questions. Just keep it structured. And you can even ask them, Dr. So-and-so says that maybe I don't need to be delivered yet, but you're telling me maybe I should need to be delivered. What's the reason for your difference of opinion? And be very frank. Most physicians at the end of the day enjoy teaching their patients and trying to instruct about what is going on and why they think that a patient needs to be cared for in a specific fashion. So I think essentially you want to ask, all right, why do you say I need to do this? And why do you say I need to do that? And at the end of the day, it's also the patient has a choice and has a vote.
Yeah, for sure. It's a great point.
I think that is something that often gets lost, is the autonomy. For Tom and I to ever do anything, we have to have a signed consent form to treat, right? Even to be worked on in labor and delivery, there's a consent form someone signs to say, we will do the best we can for you and your baby, given all of these. Here are the risks, blah 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 blah. Right. So this patient, I hope hearing this and the people out there in internet land, it emboldens you in a very appropriate way to ask these questions that Tom is bringing up, because I think I much rather have patients that are asking all the right questions as opposed to whatever you want to do, doc. Because then the investment's not there, one, and then two, sometimes they don't understand the gravity of what could be going on. And so as Tom is saying, this is all just being honest and being very structured about being honest. I'm like,
Well, and you have to realize there's also a third person in the room. There's your nurse. And while it's not appropriate to ask a nurse, what would you do, or what's the right thing to do, it is appropriate to say, it is
Happens all
appropriate
the time.
It does happen all the time, but it doesn't mean that it's appropriate. But it is appropriate to say to the nurse, I'm concerned that I have two disagreeing physicians caring for me. Because your nurse will then go and talk to the doctors and say, all right, let's hash this
figure
out.
this out.
That the patient understands. But you do have a nurse, and the nurses see themselves, and this is the role they play. They're patient advocates within the system, and so
They really are.
You should take advantage of that advocacy.
Yeah, they really are. That's great. Thank you for that. Let's move on to next pregnancy. You've had preeclampsia, HELLP syndrome, something. You swore that you would never have another kid for like the first year, and then you decide, I really want another kid. We talked about the preconception appointment already, so this would be the time where that comes in, ideally. And we talked about, what are the sort of, baseline risk factors that would be important for someone to seek MFM. So likely has some trauma from whatever happened previously. And we find our members are like, I have an appointment for the MFM, but I can't see him until 12 weeks. That's not soon enough. I need to be in right away. And we generally challenge them that, 9-ish weeks is about appropriate for that first dating ultrasound. And MFM, sometimes some of our MFMs don't see people until they're close to 20 weeks. Any sort of advice on when they should see MFM? They have these risk factors.
Just now that you brought up this whole postpartum period, which is this could be the rest of our afternoon talking about postpartum stuff. I think whether or not you see an OB or an MFM, I think part of our challenge here is we talk about people, if they have a nice normal vaginal delivery, we talk to them about delaying another pregnancy for at least a year. Let's let your body needs a control alt delete. We need a reboot, make sure you're healthy again before you try another pregnancy, right? That's what we tell everyone, right? But I think the opportunity gets lost about preventative stuff, because after they are done seeing an OBGYN or an MFM like Tom and I, who are obsessed about blood pressures or what have you, once 6 weeks hits the floor, now they're in general medicine land. And I think there's a large culture change that needs to happen for people to, even though we've known that preeclampsia puts you at higher risk of future cardiovascular disease, that it's not as well accepted, and it's not part of normal medical practice in smaller communities. There are still a lot of providers that go, oh, you have preeclampsia, oh, you delivered, but you're fine now. No. And there are things that we need to, and all of that starts with education from postpartum day one, which we do at the university.
Show up to your 6-week appointments.
And please, for the love of God, come to your 6-week postpartum visit. You know, we for preeclamptics, we have you come back in 3 to 7 days to double check your blood pressure, and then 6 weeks. And 50% of people with preeclampsia do not go to their postpartum visits, and it's a huge problem. We will do our best to try to meet you in the middle and try to educate you about everything. But I think once they leave the kind of the protective arms of an MFM, so to speak, patients need to advocate for themselves. I encourage a lot of my patients to go, hey, if it's not diabetes and literally it was just their blood pressure, like I tell them to get a well visit, maybe 3 or 4 months afterwards, so you can check in with a primary care doctor. And I tell them, you are now at the same risk factor as this fat diabetic hypertensive, and who's short and stubby, right? We are all in the same risk factor, and I have to go see a doctor every year to get my blood drawn and blah, 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 blah. And you should too. And so a little bit of that this is a slow culture change, not only for providers, but also for patients. And as Kara is saying, this is the best thing you can do for yourself is not just see an MFM, but actually show up for your postpartum visit and then ask to see an MFM, afterwards. Be happy to see them as particularly for those really severe ones, delivered at 24, 25 weeks.
Sorry.
Sorry.
So they've waited a year because you told them to. They showed up to their 6-week postpartum appointment. They've seen their provider, their regular provider. Half of them will have their blood pressure go back up at some point during that year. And how long before they're planning to get pregnant should they have that MFM appointment? 6 months?
So a couple of points.
Yeah.
A lot of times patients want to have the MFM consult right after the delivery, and it's just not, we don't even have all the information yet. We don't always have the pathology back. We don't have so it really does need to be some time. But I think there also needs to be some time to gain some perspective and some emotional distance from the event, because a lot of the things that need to be talked about are going to be difficult. They are going to need to be considered with a clear head, and some time to grieve and get over the emotional impact and trauma, as you said, of the delivery is going to make that consultation much more meaningful. And everybody's different. I always tell my patients, your body's going to be ready much more quickly than your mind and your emotions are to be able to start to think about these things again. And so you need to give it time, and we're going to be here. So it could be, some people may need 3 months, some people may need 6 months, some people may not even want to think about it for a year. Some people may be so busy with their baby and the neonatal appointments that they can't even find the time for a year, and all of that is fine. And I think to add to what Mark was saying, we are just beginning to understand the emotional impact and the latent trauma impact of adverse pregnancy outcome, not just preeclampsia. Patients who have preterm birth for other reasons are also in the same situation. And I think we're finally starting to get this. A lot of times what I'll say to patients is, this wasn't your fault. You couldn't have predicted this. You had no control over this. You have more control over controlling your own heartbeat than you do over what's going on in utero. And when I say that, I can see them just relax a little bit and just start to, I think sometimes it's important to get that out there right away. And that helps folks think about this a little more clearly. I know that wasn't quite your question, Kara. So, but it depends on the individual. Some people may be ready in 3 months. Some people may be ready in a year and a half. It's where you're at right now.
To bounce off of something, Tom, with just one kind of process thing that we often do when we do identify those patients that either have a concerning EPDS score, but more if they may have their postpartum depression screening may be perfectly fine, but if we realize that they still had a hard time with this really rough diagnosis, we'll have them come back in 2 weeks just for a mood check. So they're there like 1 week for their blood pressure check, 2 for a mood check. And then most of the time they're seeing MFM for those reasons anyway, or at least someone on the MFM team. And then their 6-week postpartum, we pray that they come to it.
Yeah, very good. And I think a perfect segue